Hi, everybody. This is Erica Mello, and welcome to episode number 196 of Tough to Treat. And Happy New Year. I think we can probably still safely say that, even though this is going to be airing on the 25th of January. Hope you all had a safe and healthy holiday and a wonderful new year. And we're back here, 2024. And in this episode, I'm actually going to be talking about clues. We're all detectives at the end of the day. We help solve problems, right? We aren't just physical therapists. We solve problems for a living, right? So I'm going to help you in this short episode to determine what clues that you can glean from or that you can find in your patient's narrative, your patient's profile, however you want to call that, to really help you prioritize your assessment. 80% of the diagnosis is made by the words coming out of your patient's mouth, right? What they're telling you, you can make a pretty good idea or diagnosis right there. Yes, we do need to watch them move. We are movement experts, but what comes out of their mouth and what their subjective is will tell you what movements to look at. So in this short episode, I'll be diving a little bit into a couple of patient scenarios. And also, Susan and I will be at CSM. For those of you who are listening to this ahead of that, we'll be speaking on at 11 a.m. on Thursday morning, the 15th. Susan will be speaking separately as well at 8 a.m. on that day, on the 15th. So come by and say hi. We would love to see you. And if you are new to our podcast, this welcome. And our website is toughtotreat.com. And actually, over the holidays, I was compiling a list for somebody, and I was just sort of putting in, in our search bar on our website, low back pain, pelvic girdle pain. It's amazing how many episodes we've recorded to date. As I said, this is 196. So if you are new and you're interested in a certain region of the body or a certain patient profile, type those keywords into our search bar, and several episodes will pop up with those words, or if we have actually done and dedicated an entire podcast to that. And to our loyal listeners, thank you. And if you have not yet left us a review on Apple Podcasts or wherever you listen to us, we would really, really appreciate it. We do read these reviews honestly, and it means the world to us. Thank you, and on to the episode. Hey, everybody, this is Erica Mello, and welcome to episode number 196 of Tough to Treat. And as I mentioned in the introduction, I'm going to be giving you a short, sort of teeny little masterclass on how to help you find the driver quicker or more quickly from your patient's narrative. So basically, clues in the narrative, the subjective, to help you hone in on that driver quicker, and also to help you choose some movement patterns that will help you speed along your assessment. I mean, look, at the end of the day, time is our biggest limit in the clinic, right? And if we can really hone in on our detective skills, our clinical reasoning, and the way we associate past injury history and past movement history, and how we associate the patient's history with their current problem. I mean, that is really the key. Okay, so I'm going to give you three very short patient scenarios. Actually, Susan and I will be live next week doing one together. But this week is obviously a shorty for me, so it's going to be three patient scenarios. I'll give you the background, and I'll give you some clues as to how, sort of clues as these patients I've treated and discharged. Okay, so, I saw them right to the end. And so it'll be very much, this is what the patient has, this is what they told me, this is what their movement history is, what do you want to prioritize? Okay, and so ultimately, you want to think about, and I've talked about this a lot on my course and in some of the sort of educational sessions I've done over the years, is that you really want to go back. It's not just getting their history. You have to do a timeline, look at the chronology, right? I always say, what set them up, right? What sets your person up? My first injury was a left ankle sprain. That set me up. And then what kept them there is their movement history, their injury history. We adapt to our injuries. We are humans. That is normal. So ultimately, we are a product of our compensations, a product of our adaptations until we lose options for movement. And that's when we end up in the physio's office, the doctor's office, right? So what set them up? What is your first injury? I don't care if it was 7 years old. Okay, it will set you up and you will adapt to that. And then you may have another injury and then you'll compensate. So, what set them up? Just think about it. What set them up? Say this to yourself. What set them up? And then what has kept them there? Is it a movement pattern they've done over again? Is it a sport they've done? I think Susan and I talked about a rower patient of mine who's left sweep for many years, college, high school. When I had him stand up, he was so far to the left, it wasn't even funny. That is the movement pattern that kept this guy there. So I want you to think about that when you're getting your patient's story. Okay. So this first patient, everyone's going to have a different story, right? And so you want to think about after you hear the patient's narrative, what regions of the body will you prioritize? So this one is actually a short one, but I found this to be the patient not easy, to be really honest. It was a patient here in New York, obviously New York City where I treat. She had complaints of it was neck pain. So it was basically, Erica, I can't do a push-up because my neck hurts. Okay, and so why does she have neck pain, and why is that, right? And so that's sort of what I got coming right out of the box with her. And ultimately what I think you want to focus on over time is, okay, she's telling me she has neck pain when she can't do a push-up. What is her movement history? Okay, so let's go back to the narrative. She was a competitive tennis player all throughout high school. That's her movement history. Active person, personal training here in New York. High level tennis player. Think about what we know. If you have a patient who has had a lot of injuries, they play a particular sport, what regions of the body are stressed with that sport? Tennis is obvious, right? Shoulder, neck, GH, thorax. What I have found with tennis players, they may have elbow pain, they may have, hip pain, but if it's a chronic problem that keeps coming back, the driver is elsewhere. Okay, it's generally up higher. I've seen a lot of players who had very compressed thoraxes. Okay, it's common, especially on the dominant side of play, right? So this patient that was her movement history, tennis player, but high level, right? So think about that, the stresses associated with the sport and how long your patient has. So right then and there, when she tells me she's a competitive tennis player, has played tennis, on a regional basis competitively, you're not pro, but active and competitive for many years, I'm thinking, okay, thorax. She doesn't even have pain in her thorax. I'm thinking I need to go there, right? So her injury history, this is important with this patient. She had bilateral anterior compartment syndrome with releases when she was younger, right worse than left. Okay, when she saw me, she was 1 year postpartum. She also complained of bloating and digestive issues. So, Erica, I can't do a push-up without neck pain. Erica, I'm bloated and I have digestive problems. Okay. Not a lot of history, right? Not a lot. But her story right there should tell you something. I did ask if she had some heart palpitations. It is common with people who have dysfunctional thoraxes, who've had heart palpitations and they've been worked up cardiac wise and they're all clear there. It is common that they do have undiagnosed heart palpitations that just occur when they have dysfunctional thoraxes. So that also told me something about her. So she's basically, I can't do a push without neck pain, and this is her history. So what are you thinking right there? Okay. Number one, she can't do a push-up. So what's going to be on my priority list right there? I don't even need to talk. I mean, you don't even need to go further in the history for this particular case. Okay. Young, in her 30s. So we have tennis player, competitive tennis player, bilateral anterior compartment syndrome, a history of right shoulder problems as well. And, her neck pain turns on when she does a push-up. Okay. Postpartum, bloating. When you have somebody who has a lot of bloating and digestive issues, notwithstanding the abdominal stuff that goes on with that, the thorax is a huge, a very important area to look at and assess when you have these subjective complaints. So, in terms of priority list, what am I looking at? I can't do a push up without neck pain, right? Number one, you got to look at her neck. That's obviously her area of meaning. So that's the magnet board, the priority list, that's on there. You write that down. C's fine. Okay. Number two, bilateral anterior compartment syndrome. Both her feet are going on that list. When someone who's had that, both of them released at a young age, and she's a tennis player, they're going on the list. Bilateral foot, right and left. Keep postpartum, bloating, digestive issues, heart palpitations. Thorax is going right on that list. The fact that she's a tennis player, going right on that list, thorax. Okay. The fact that she did have a small sort of a diastasis, I put the pelvis on the list, but lower down, because I knew based on this narrative, based on the fact that she was a high level tennis player and the fact that she had a lot of issues with bloating, heart palpitations, it most likely was not her pelvis at this point. At this point, 1 year postpartum. Okay, so based on that, what movements would you assess? So depending on your skill level, it may be hard for you to actually assess a push-up. You can certainly watch it. I would, if you don't feel skilled enough or confident enough to do that, which that's fine, but look at it, video it, and then look at it later. Okay. So the whole title of this episode is what clues in the narrative, or in her history can help me make a diagnosis quicker or help me, sort of make my assessment more efficient. So once again, tennis player tend to have significantly compressed thoraxes. Thorax is going on the list. Her history, bilateral anterior compartment syndrome, the feet are going on the list as potential drivers. Okay, you need to put your feet on the ground to do a push-up, right? Postpartum, bloating, digestive issues, I'm all looking at the thorax, especially with bloating in the abdominal cavity, okay? Thorax innervates the abdominal wall, people, right? So that's important to look at. Heart palpitations, undiagnosed, cardiac worked up fine. Where does the cardiac sinus sit? The thorax. So right then and there, I've got a list. So because she can't do a push-up without neck pain, I look at a push-up. Do I do a full-blown push-up on the floor? No, that's definitely hard to assess. Okay, even at my skill level, that's hard to assess. I do a wall push-up. I look at her, okay? Because of her significant history of the anterior compartment syndrome bilaterally, I needed to look at another movement pattern. One that wasn't even relevant to a push-up, but I needed to see what her center of mass did when her feet were involved. So I took a look at a wide and a narrow-based squat. When you vary the base of support, Susan and I have talked about this many times on the podcast. If the person moves differently or looks differently with a narrower or wider base, you're looking for something up high, you're looking for something down low as a potential driver or secondary driver. It could be the feet, the knee, the hips, right? Because of her foot issues, I did this. I had her do just a narrow base squat, wide base squat. Narrow base squat, she went way to the left. And that's significant, okay? And this is not about, what I did in the evaluation or how I treated her, but it's really about what clues in her narrative. Her history of anterior compartment syndrome was significant. It was a very, very strong secondary driver. If you missed this and just treated, for example, her GH or her thorax, and you started to progress her to upright activities, you would be stuck because her foot issues would not have been addressed, and you would have reached a plateau, and then she wouldn't have been able to progress. I've seen this, okay? So because I looked at it initially, I was able to treat her foot at the same time and progressed through upright activities and movement patterning so she could go back to doing a push-up and going back to playing tennis. And so ultimately her drivers were her thorax, her upper thorax. She had a very small glenohumeral driver that came in at very high levels of overhead motion, but her primary driver was her thorax. I can't stress this enough how important this region of the body is. And she's a very strong secondary issue driver that was her foot, her right foot. So once again, I can't do a push-up without neck pain. I'm not going to, as I said, go into the evaluation, but there were significant clues there that led me to her eventual drivers. So I hope that case was helpful for you. So we're going to go the next one is also a push-up. I did these purposely back to back. So these are very different drivers. Okay. So this patient had treating her on and off over the years, but she had come in to see me for a right shoulder issue when she did a push-up, similar to the last patient, also postpartum, but many years postpartum. And her main issue is her right glenohumeral joint is really, she just felt it compress. Those were her words when she did a full push-up. It wasn't like the first patient, Erica, my neck hurts. It's Erica, my shoulder hurts, right? For the full push-up. Okay, so these are very similar complaints, but very different drivers. Okay, so I will give you I'll be a little bit quicker with this one. So similar age, about 10 years older than my last patient. It was mid-40s. Not into menopause at this point, but feeling some changes there. Injury history. So it was her right shoulder. Injury history, left knee problem. No like surgical history here. It was basically an old chronic left knee issue, old chronic left hip issue, old left low back issue. Are we seeing a pattern here? Right? Left knee, left hip, left side of her low back. Okay. History of a herniated disc in her C-spine with bilateral radiculopathy symptoms in her history. So she had a right shoulder, okay, issue. When she was postpartum, after she gave birth, she's 3 kids, she carried her children on her right hip. So I'm going to go back again. History of the left knee, left-sided hip issues. Her first issue was her knee. Left-sided hip issues, left-sided low back issues. Is it no wonder her right shoulder hurts? Remember, we offload our painful side, right? The C-spine herniation was, I would say, the more recent one, okay? And the postpartum was her with her 3 children, I would say probably spaced 2 to 3 years apart, chronically carrying on her right hip. So she's offloaded her left side because of the injuries, right? And she carries her kids on her right hip. So there's a movement pattern right there. Okay, we've offloaded the side. What set them up? Remember what set them up? That set her up. And it was easy for her to carry her kids on her right hip, right? And so that was the movement pattern. From movement history, very active. Skiing, swimming, running, not, like my past patient was very much into tennis. This person was just an active individual, like to do a lot of sports, right? Very active with full weight bearing, hence the push-up. So what are you all thinking? Once again, not a long history. I recently spoke here in New York for the New York Physical Therapy Association at one of their evening events, and I gave a history of somebody with a chronology that would have made your toes curl. I mean, it was it was a former patient of mine who I looked at the timeline. I remember we need to do a timeline, right? Her timeline started like 1980. Okay, and I looked at all of this, and it is amazing that we were able to sort of put it together in the end. But and she got better. But my point is that we don't need to make this difficult. But you're going to see those difficult patients where they have a lot of injuries. It is up to us to clinically reason through what is important. And I'm not going to present that patient here because that is actually better on video. So we actually may do a video podcast one of these days. I've always been asking Susan, we should do a video, and maybe one of the shorties I'll throw up a PowerPoint, but that is much better explained on a video. Okay, so this person is a bit more on the, I don't want to say on the simple side because none of these people are, but the less complex side. Okay, so why can't I do a push-up, right shoulder issue, left knee, left low back, left hip, herniated disc, bilateral radiculopathy equal. Okay, and she had a right shoulder issue. So skiing, swimming, running, pretty much all. I mean, the sports are very different. Swimming was a big one when I saw her over the summer. So that was sort of in her brain. She could swim pretty okay. Okay, you have a right shoulder problem and you can actually swim. Hmm, interesting, right? Who with a right shoulder problem, really where the driver is the shoulder, can swim well? Not many people. Okay, if your shoulder is really your driver, you can't do a full freestyle swim that well. I believe, my opinion. Her driver was elsewhere. Okay, so what are we going to prioritize in terms of movement patterning? In terms of a movement, okay, once again, you can do a wall push-up, which is really what I did. So Susan and I have talked about on the podcast other ways once we have our magnet board. So my magnet board, yes, it's the left knee, the left hip, or lumbar spine, but I'm looking at the C spine because of the bilateral radiculopathy. I'm looking at the neural system because of her radiculopathy symptoms. Obviously, her right shoulder, okay, and her thorax. And I'll tell you why. Because when we want to shift our weight over, it's very easy to do that via our thoracic spines. Okay, very, very easy. It's very hard for us to sort of shift our pelvis and our feet. We can offload our feet pretty easily, but a lot of the translation of the way to offload a painful side comes from our thorax. So because she carried her children on her right hip for so long, I mean, your thorax just goes. It just goes. It goes to the path of least resistance. So I put that on my magnet board. Okay, so the priorities were obviously the shoulder. You have to assess what's meaningful to them. Someone comes in with shoulder pain, and you don't look at their shoulder. I mean, even if it's for a few minutes, you need to do that, right? So, right shoulder, C spine, dural, neural tension, the nervous system. We're always, I mean, at the end of the day, we're always looking at the nervous system. That's always on our radar. But being more specifically here, with the push-up, what nerve you're thinking of when you go on the wall? What neural tension pattern are you thinking of? Right, for push-up, you're at median nerve, right? So as I was starting to mention earlier, Susan and I talk a lot about normal, narrow, wide, right? I did that in the last case. Do the same thing on the wall. Just go normal, narrow, wide stance on the wall with your patient's arms, see what they look like, see what they feel like. Especially this person, these last two patients with the push-up. So based on that history, you're going to really streamline your assessment. Go on the wall, have her do a push-up, normal, narrow, wide. I did not do that with the last patient, so I was interested in her feet as well. Okay, this particular patient, I did. So she had a very difficult time doing the normal narrow. All of them, they were very hard. She didn't look right. Her shoulder compressed. But going back to the narrative, is that it's very important that we piece out parcels of her injury history and clinically reason as to is that potentially can that potentially be a driver? Okay, she can swim. She can swim. She has a shoulder problem. Is it her shoulder? Maybe it was not her shoulder. She's had a recent history of a radicular pattern, bilaterally with a significant herniation of C spine. Okay, so you think about what's the exercise or the movement that she cannot do. What is stressed in that movement? Similar, what sport does the person play? What regions of the body are stressed? This particular patient didn't have I mean, she did a lot of things, right? So median nerve, right? Think about median nerve. It's full knee extension. Oh Lord, a full wrist extension, right? Elbow extension. You can play with the head position. So that's a big clue, and that needs to go up on your magnet board, and that needs to go into your assessment. Okay. So fast forward, her dural system, that was her driver. The minute we started to get the dural system, the neural tension better, I put that in air quotes, doing the push-up, it really helped center her and it really got her better. So just because someone has shoulder pain when they do a push-up doesn't mean it's their shoulder. And that's really why I wanted to bring her up. Okay, so the last case, I'll make this short, is a patient. I might have told her a while ago. She was actually a physio, and her complaint was, Erica, my left hamstring hurts when I run up hills, and my left SI joint, right, plantar, her left side of her PSIS, her pelvic girdle, when she walks her dog, okay, or when she walks long distances. And she's like, had my pelvis treated, but it's not helping. She was a pelvic health physio as well, so she's done had internal work, did the traditional pelvic health therapy, did not make her better. So her main complaint was left high hamstring, right up at the ischial tuberosity, which is part of the pelvis. That really got her when she ran up hills, and her left sort of pelvic girdle, left SI joint, left PSIS aggravated when she was walking her dog or just generally walked long distances. That was her story. That was her narrative. I often think about there's a book called Noble Listening, and I think we listen more than we talk, or we should listen more than we talk with our patients. Sometimes that is hard because we try to interject our narrative onto them, but we really should listen more than we speak. And I found this book, it's Noble Listening by Mark Brady, called Contemplative Practices for Fostering Kindness and Compassion. And I think that we all should endeavor to really listen with empathy. And I mean, not listen and look down at your paper the entire time, listen and look them in the eye, right? So, whenever we have a patient who's pointing to their pelvis, we're thinking, oh, is this a loss of control? Before we've even had our hands on them, once again, it's about clues in the narrative. Is this a loss of control? Maybe, right? Running, she had a running and a walking issue. So what do they have in common? Her main issues were, running and walking. And what do those sports, quote unquote? Walking is a sport, people. At least here in New York City, it is. Let me tell you. It's a one-legged stance phase. It's thoracic rotation, right? You need to have anybody who treats a runner and doesn't look at their thorax needs to look at thoracic rotation, right? So one-legged standing, that's a common movement pattern that we can assess pretty safely, right? You look at any pictures of runners over the years, on a freeze frame from the Olympics, they are in significant thoracic rotation and one-legged standing. So those are the two movement patterns you could assess just based on her narrative, even though she's, got hamstring pain, right? Or pelvic girdle pain. So I think that it's important to really think about, if she has a couple issues, what's the commonality in terms of running and walking? And once again, it is one-legged standing and thoracic rotation. Her past injuries, she had a prior hamstring injury. And as a person who's torn their hamstring twice, myself, it comes back. Trust me. So, and we all know this. And so she had a prior injury to her left hamstring a couple of times, super flexible, marathon runner, bilateral ankle sprains. Right then and there, she's got a high hamstring complaint and a pelvic girdle complaint. Because she's had ankle sprains, what's going on your magnet board? Right, your feet. Just write it down. I'm not complaining of foot pain, but that's got to go on there, okay? Marathon runner. Anybody who's a runner, you got to look at their feet. I don't care if they're coming in with shoulder pain. You need to look at their feet, especially if the running is the problem. Prior hamstring issue. Yeah, you need to look at the pelvis, okay? So, and obviously that's her meaningful area. She also went through a yoga teacher training program that says a lot about someone's movement patterning. And she's also a Pilates instructor. So a physio, right? So a physio who's had, just an active physio, who's had, prior hamstring injuries, bilateral ankle sprains, went through a yoga teacher training program, was also a Pilates instructor, okay? So you really want to think about, she didn't have a lot of other injuries, okay? But she did have numerous ankle sprains, numerous. And I mean many, at least 3 on each side. That's significant. I've sprained both of my ankles once or twice. My feet are one of my drivers from my issues. But once again, ankle sprain, who hasn't had an ankle sprain? There are people who haven't, but the majority of your patients will have had an ankle sprain. The foot needs to go on your magnet board. And I'm speaking a little bit about this at CSM, but the foot and the pelvis are extremely related. You can pull up a picture and make a direct connection, and you could also make a connection in the brain, and you could also make a connection with how our center of gravity, okay, or how we respond to center of gravity. So if you're looking at the patient if you're a pelvic health therapist listening to this and your patient has had pelvic girdle pain or any pelvic health issue, you need to look at their foot, okay? So this particular patient wasn't complaining of any internal, like she had no incontinence, no pain with intercourse, no problems leaking, none of that. It was just external. my right on, like when she cupped her hand right around the back of the back. So, but we need to know that once again, the narrative, that's what this episode is about, the narrative. Prior hamstring injury, twice. Marathon runner, what does that do? Foot. Bilateral ankle sprains, foot. Once again, she's not complaining of foot pain. Okay, so in your brain, what are you looking for in terms of a I would say a priority list? She had one other complaint, where she basically complained of a lack of power in her hamstring as well. So when someone has like a lack of power, or they have a special test that you want looked at, find your driver first, and then you could look at that special test if um, if it's meaningful to the patient. So for this particular patient, she had a lack of power in her left hamstring. I did do a prone hip extension test for her, just as so that I could prove to her that it wasn't actually her hamstring, that was her driver. Okay, but I'm just digressing here for a bit. But that was another one of her complaints. Okay, pain when I go in my pelvis, my left SI joint, PSI is when I go up the stairs, when I walk long distances, and when I have and I just have a lack of power in the hamstring, probably going up the stairs. Okay, what's on your magnet board? Pelvis, obviously, that's your complaint. Anything else? Her feet, right? Definitely her feet, both of her feet. And I would look at, I know the pelvis and the hamstring are related, but I would probably look a little bit at the knee area, just because the hamstring crosses the knee. Okay. But it was high, but it was low on the list in terms of high hamstring, but it was low on my priority list. So, I mean, her pelvic girdle definitely is on the priority list because it's her meaningful area. Her feet are on the priority list because she's had multiple ankle sprains. Her knee is on the priority list because the hamstring crosses the knee. Right then and there, based on her narrative, I've got, some issues, some areas to look at or to assess. Okay. Anything else? Just think in your brain, is there anything else that you would want to assess on her? Probably not. Probably not. You're trying to make a hypothesis, right? And so with her, you just look, take a picture of somebody, or look at a picture of somebody going up the stairs. And there's her left leg. Okay. And her ankle sprains, I believe, were equal bilaterally. So if you think about when someone's going up, I'm actually looking at a picture now. When someone going up a step when they're running, that right leg is in front, that left leg is pushing off. She had a lack of power there, no wonder, but she's had her pelvis treated. I'm assuming it got treated appropriately, but her pelvis was not her driver. So think about what it takes to go up the stairs. Push up the stairs, push off. When you're pushing off, just think of somebody just running, doesn't even have to be up the stairs. They're basically at the starting block. One, let's say the left leg is behind. What muscles do you need to push off? What regions of the body need to be functioning optimally to get that strong push and to get that extra edge? Where does that start? That starts at your feet, right? You need that good push off, right? So my hypothesis before I actually assessed her, saw her move, was that she was pushing off that left leg, the back leg, with the foot that was not optimal. Okay, where there was a loss of control. I did not know because I hadn't assessed her yet, but I was hypothesizing that the back leg and the foot was just not controlling her movement well, which in turn affected the length tension relationship of her hamstring. Take a look at the anatomy. You can see if you don't have a controlled foot, that if you're not pushing up optimally, you're not using your calf muscles appropriately, you're over recruiting, maybe posterior tib, it will go up the chain to your hamstring. So that was my hypothesis, okay, before I even assessed her. And, once again, this isn't about the assessment. Her foot was her driver in the end, and treated successfully and discharged. But why would someone's pelvic girdle pain come from my foot or come from her foot? It could be anything. It could be a prior foot injury, which it was with her. It could be a compensation. It could be offloading the opposite side. It could be anything. And so I do believe that her old foot injury caused her a non-optimally load through her left leg. Since she was hypermobile, she compensated for a long time until her pelvis lost its ability to control movement with higher load. And it affected the length tension relationship of her hamstring. And so, this episode is really about clues in the narrative. And so do not underestimate the person's past movement and injury history. Do not blow through that. It will save you a ton of time. Hope you enjoyed this. If anybody has any questions about any of our episodes, please email both Susan and myself at toughtotreatpt@gmail.com. And once again, if you're at CSM, we'd love to see you. And we'll see you on the next episode.